Hi, this is Junaid with another video. Today we're going to discuss telemedicine billing, a guide for physicians. I'm extremely grateful for VeeMed for sponsoring this video, and also a special shout out for them because they have actually donated VCard, their tablet-based telehealthcare system, during this national emergency. They're a great company to work with, and they're sponsoring me, so I'm again very thankful to them. One of the key things that you have to understand is that these policies are changing quite rapidly. And one of the best resources that you want to go to is Center for Connected Health Policy. That's the place you want to be to look for federal level policies, so you can actually see what the changes have been made, for example, due to the COVID-19 pandemic. And more importantly, you can also see current state laws and policies and legislations in your own state, which is extremely important, as we're going to discuss further, that things continue to evolve as we move forward, especially in the field of telehealth. This particular guide, introductory guide for fee-for-service, published in January 2020, the link is down at the bottom. Some of these links are also in the description as well. As we know, telemedicine day has finally come, and people who are reluctant to adopt it now are potentially forced to adopt it. And we're going to see this evolution exponentially growing as we move forward. And this is not new. I mean, people have been discussing this. This is an article from last year, that how things are going to evolve significantly, especially in telestroke, teledialysis, and critical care and acute emergencies and pharmacy. And this pandemic has basically thrown everything into focus. This is the main fact sheet that we're going to work with. I refuse to use any resources that are made by other professionals or hospitals, etc. This is directly from CMS. This is the fact sheet that was published by them, and it actually divides into 3 different portions. Number 1 is Medicare telehealth visit. How do you define telehealth? Telehealth is a telecommunication system between a patient and a provider, and it is synchronous or live to be actually considered telehealth encounter. There are 2 basic types of encounters. One of them is office-based, and then the other one is inpatient or emergency. The second one is virtual check-in. The virtual check-in is, to be honest with you, not worth my time or anyone's documentation requirements to do this for the money that Medicare pays. And lastly, eVisits. And we're going to continue with all 3 of them to discuss what these mean. So the first and foremost is the inpatient. Inpatient means that a person who is either in the emergency room or in an inpatient setting. And these are basically real-time recorded audio and video. Recorded means that it doesn't have to be stored or forwarded, but it has to be real-time. And the initial consultation services includes these 3 codes: G0425, 30, 50, and 70 minutes. Subsequent follow-up of the same inpatient setting has different codes. It's 406, 7, and 8, and these are the time corresponding to those particular CPT codes. And finally, those patients who require a prolonged service or has special needs like critical care has 2 different codes. For the first 60 minutes, it's 508. For additional 50 minutes, it's 509. Special code that is written here is 0459, and this will be the evolution of the inpatient pharmacy management via tele as well. So these are inpatient codes: emergency/inpatient, time-based coding, and it is divided into these: initial, subsequent, prolonged, and pharmacy. The second one is outpatient, which is face-to-face as well, which is also live care that is given to the patient, divided into initial and subsequent. The codes are 99201 all the way to 205, from 10 minutes to 60 minutes. And then if you look at the subsequent, it's 211 to 215, all the way from 5 minutes to 40 minutes. Again, these are patients in an office or an outpatient setting. Office is provider's office, rural or hospital access, and we're going to go to originating site requirements. outpatient setting is defined, to be honest with you, by every insurance plan, state, or even local facilities, like for example county level, etc. So you have to check at your own particular place what outpatient setting is defined as. If it's a dialysis patient from a federal level, you can provide care at home. But these things are changing so rapidly, I just wanted to make sure, and we're going to discuss this further as well. So these are outpatient codes to see and evaluate patients. These are not just time-based codes. You can actually use them as evaluation and management through history exam and MDM. So you can use them either as a level of service or length of service, whatever you prefer. Same with the subsequent. Now, this is a special category. These are outpatient patients, but you're providing non-face-to-face care, care coordinations, etc. And there are two different kinds of them. Number one is a simple plain phone call, but you have to document that phone call, which you generally do anyways. The difference between this phone call and the one that is actually done like we normally do is, for example, if I have a patient that comes in and I ordered a dilantin level, and I called in and said, hey, your dilantin level was okay, or one of my staff called it, that's not something that we can put that under this particular code. What we have to say is an established patient with a new complaint that does not require an office visit. So in those cases, you can actually say that, you know what, it's a very simple thing that, hey, by the way, if, for example, my dilantin level is not okay, etc., and it will not require a visit in the past 7 days or a future appointment, or in a situation that a person actually has a common cold, but it is your, IBD patient, or it is your MS patient, you can just sort of do that over the phone call. And if it does not require an office visit, then you can bill these codes for phone calls only. eVisits is a special code that actually requires constant communication with the patient-initiated communication. It is very important that these communications are patient-initiated, and then you're using, I don't know, a secure portal, a HIPAA-compliant messaging, a secure email message, etc. And in these situations, what you have done is that you have basically asked the patient is asking you questions about that visit, and then you actually provide support to them. For example, you prescribe topiramate and patient has issues with medication after a week or so, and you answer that call. Then the patient calls back again after 2 weeks and says, yeah, patient has GI upset. What are we going to do? So this is basically in areas where you have not provided face-to-face care, and actually will not be getting into a proper office base or an E&M service, then you can build those codes. So phone calls, just plain phone calls. And then the second one is eVisit, which is by definition a communication through an online portal. So that's the difference when we are looking at outpatient, non-face-to-face encounters. There are other things that we need to consider. One of them is originating site facility fee, which is, to be honest with you, dismal, $26. However, most of the time, hospital is eating the cost of this. The second is virtual check-in. As I said from the first fact sheet, I'm not going to even discuss this. It's $14, and the documentation requirement is huge for those $40. The other one that I have looked into is interprofessional internet consultation. These are non-face-to-face consultations done over telephone, internet, or electronic secured channels, etc. And a physician who is providing that interprofessional consultation can potentially bill for them. The word can and potentially is because this was added in 2019, and I haven't seen personally at least billed for it. And things have been rapidly evolving. So take it with a grain of salt, double check with your personal or local billing specialist to see if this actually qualifies. There are two different levels. Let me just go into that. So the first one is 99446 all the way to 99449. These are all physicians. So these are physician-based codes according to the time. And then the requirement is that you document what kind of service you provide interprofessionally and that's pretty much it. There's another code that, for example, if you're a nurse practitioner or your qualified provider is providing care, reviewing the chart, etc., for more than 16 minutes or so, you use that code, and then the consultant, when reviews that NP, etc., can actually add about more than 5 minutes of code in that. So for example, if there's an established stroke patient calls in, hey, I'm having dizziness, the nurse practitioner spoke to the patient, looked at the chart, looked at the past imaging, etc., calls me up and presents me the whole case. It took about 20 minutes of her time, and when I had to personally review it, it took me 10 minutes. So she will bill, she will bill this number 99452, and I will bill this number. Again, take this with a grain of salt. I was not able to find these codes in the official CMS 2020, but this is of course added in 2019. If you look at the very long document of 2,000 pages, it's still included. More to come if I find more information, but for now I want you to be aware of it, and I want you to discuss with your local billing specialist on these codes. There has been a lot of discussion about modifiers, so I'll just go through that in a minute. So this is all Medicare based. If it is G0, that is telehealth service. G0, this is all between 2019 and 2020 update. And the idea was that we want stroke specialists, and this was truly done for acute stroke. So they removed the originating site requirement, and the idea was you use all of them to actually produce this particular code, mainly for stroke. Now people have been using is GT, and that's after the pandemic. GT means basically providing care in critical access hospitals, and these are provided at 80% of their normal fee, and you can potentially use any code and modify it with GT to say that this is because that I provided this particular care over tele. These things are rapidly evolving and changing due to the pandemic, but I want you to be aware of that, and some hospitals are using this as a main method to code for patient services, especially in private practices, in private insurance plans. However, Medicare has their own requirements and doesn't apply directly to them. Medicare codes are basically what they have been all the way into this fact sheet, and they potentially accept these codes as they have notified in their official document. So originating site restrictions is the key issue. So from 2019 to 2020, the biggest issue was acute stroke, and then there were not enough areas to actually provide care. Same with the end-stage renal disease, opioid disorders, behavioral disorders. And from 2019 to 2020, Medicare took all of these originating site restrictions away. And these are the places that they actually said that they're going to originating sites are considered to be used. For example, renal dialysis facility, home of the beneficiary of the ESRD, mobile stroke units, SNFs, critical care hospitals, etc. As you can see, it does not actually show patient's home except for ESRD patients. However, as I said, things are evolving very rapidly because of this pandemic, and things may potentially change. And people have been asking for that change with the Connect Act. And this may be the time that, as I said, telemedicine will become the way of healthcare, at least for some time. So this is original from prior to 2019 and as of 2019, how things changed, and then how moving forward, basically this thing will be implemented in 2020. So these are the three things that are end-stage renal disease patient home, renal dialysis facility, any hospital critical access for acute stroke. For acute stroke, it doesn't matter. If you have a mobile stroke unit, if you have anything, all restrictions on acute stroke has been lifted. And then substance abuse and mental disorders was basically added in 2019 as law and 2020 as reimbursement. There are significant still challenges as we progress through this. Number one is pay parity. As I know, only California is the state that actually has pay parity. What that means is that if I have regular face-to-face visit physical in the clinic, and if I provide the same services over tele, I should be paid the same. That particular law is only enacted, as I know of, in California. As I said, things are changing rapidly, and this information, by the time I present it and you see it, may already been expired. The second big issue is pay transparency. Again, Medicare pays at one rate, so does the private insurance companies pay at a different rate. And the idea is it's not just the pay parity for us as physicians, it is more importantly for also the patients. That is there any pay transparency, co-pay transparency, supplies billing, etc. And these all needs to be worked out. Interoperability is going to continue to remain the challenge for both cost containment, because the whole idea behind telehealth services is to reduce the cost. Believe it or not, when I see my epilepsy patients, for them to come to my clinic costs more than anything I do in the clinic, maybe by a tenfold. So if I don't have access to their records from either the hospital, nursing home, etc., the last time I did an MRI, these things will significantly change the way we work. And interoperability between electronic medical records, telehealth platforms is the key. And this will take some time. ONC has made some significant strides towards it, but we'll see how it pans out. Another big issue is cross-state licensing. Last I checked, again, this is at the center of connected health policy, that you can see if certain states allow a special kind of license called telemedicine license. And this will, again, as I said, continue to evolve, and things will continue to change. So people will, these states are getting into it. Right now, at least 29 states, for example, have special telemedicine licenses, including Florida. And this would continue to grow, and hopefully this goes to 100% of all states soon. And there should be, in my opinion, one federal level telehealth license for you to provide care in all states. Again, this is a policy change that needs to be done, and these are one of the challenges that we are facing. The other big issue is credentialing. So credentialing is annoyingly difficult, and believe it or not, it's set up so awfully that I can't believe. Even if I am credentialed at the main tertiary quaternary center as the expert at the Pinnacle, whatever, I have to get a separate credentialing done at a rural hospital in the same hospital system. Annoying. So I think there is an evolution in the credentialing process. It has to be made electronic. It's kind of stupid in this day and age that I have to print it out, write down the reference for a physician, scan it, and email it. I think this should be done all over, all electronically. And as a matter of fact, profiles need to be set up for physicians that I know. I can actually pre-click them, and there should be just one email to me. Hey, X person asked for your reference. Do you agree to send it in your profile through saved preferences? And you can just send it, and this should become fast, easy, and approachable. The last problem is connectivity. Outside the hospital systems, I think the connectivity works better, interestingly. Inside the hospital, the Wi-Fi issues are a problem. No matter if you have 5G or whatever, 6G in the next few years, the question still remains that inside the walls of nursing home facilities, clinics, and hospitals, connectivity remains a big issue. And I think significant sort of capital infrastructure improvements need to be done within the hospital walls to improve connectivity for us to deliver telehealth care. Having said all that, this is something that has changed the way we actually view telemedicine. And one of the requirements that has been waived by the COVID-19 is the relaxation of the HIPAA policy. And it specifically says that you can use FaceTime, Skype, whatever, to actually provide care in good faith. However, I personally, I'm very reluctant to do that. And the reason is that there is availability of clear HIPAA compliant solutions like VeeMed, VClinic, VCard, VDoc, and there will be a review coming soon. So why not use those services? And this is not something that's going to go away. We're thinking about this to be at least lingering on for a year or so, and then who knows, maybe it's the way of the world moving forward. I think this is something that you should invest your time in to look at different options. Of course, This is a sponsored video from VeeMed, but I definitely love their system. The more I'm getting to know it, I'm actually waiting for another update to come, and I will have the review soon. So all of these things considered, if you have the possibility, use a HIPAA compliant system. And this is going to be the way of the world. It's not like it's going to be going away today or tomorrow. So might as well look into it and then try to use HIPAA compliant services. If not, then of course, in good faith, do provide care for your patients. Again, thank you for VeeMed for sponsoring the video and donating. Thank you very much. Please subscribe and share.